Bismillahirrahmanirrahim. I welcome you all to the Comstech online seminar on promoting cancer awareness and advocacy for radiation therapy technologies and medical physics in OIC countries. First of all, I start the proceeding with the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان صدق الله العظيم.
Allahu Akbar. Now it's my pleasure to invite Excellency Dr. Iqbal Chaudhry, the Coordinator General of OIC Comstech, for his opening remarks. Dr. Iqbal Chaudhry.
Distinguished speakers, respected colleagues, valued partners from OIC member states and Africa, Assalamu alaikum wa rahmatullahi wa barakatuh. It is a pleasure to welcome you to this important Comstech online seminar focused on promoting cancer awareness and advancing advocacy for radiation therapy and medical physics across the OIC countries. I extend my sincere appreciation to our distinguished speakers and participants, particularly our experts who are not only internationally recognized in their respective field, but also well-versed in the context and challenges of OIC member states. Having worked extensively within OIC countries and other developing nations, their experience brings valuable regional insight to today's deliberation. Ladies and gentlemen, cancer has been a major menace. It has now emerged as a significant and growing public health challenge, both globally and all across the OIC member states, particularly in low and middle income countries. Persistent challenges such as late diagnosis, limited public awareness, inadequate access to modern treatment technologies, and shortage of skilled professionals continue to widen disparities in cancer treatment and outcome. Addressing these gaps is not only a medical imperative, but also a matter of equity, human dignity, and sustainable development. The theme of this event is both timely and strategic, as February 2026 is a Global Cancer Day. By integrating cancer awareness, early detection, radiation therapy, and medical physics capacity, the program addresses the full continuum of cancer care, from prevention to diagnosis and from treatment to health system strengthening. These areas represent critical entry points where science, technology, and innovation can deliver tangible and sustainable impact. Ladies and gentlemen, enhancing awareness and promoting early detection remain among the most effective and cost-effective approaches for reducing the cancer burden. Achieving this required not only clinical intervention, but also trusted health communities, communications, engagement, evidence-informed policy support, and experts. Equally important is the strengthening of radiation therapy services and medical physics capacity. Radiation therapy is the cornerstone of modern cancer treatment. However, in many developing countries, including OIC member states, limited infrastructure and shortage of trained medical physicists and technical personnel constrain its safe and effective application. This highlights the fundamental principle that technology must be accompanied by sustained capacity building and human resource development. As the STI arm of Organization of Islamic Cooperation, comstech remain committed to advancing capacity building, technology transfer, training, and South-South cooperation. This event also reflects the growing importance of science diplomacy in fostering collaboration, sharing experiences, and developing collective solutions to shared health challenges all across the region. The discussion of this seminar directly contribute to the achievements of OIC Science and Technology Agenda 2026 and the Sustainable Development Goals, particularly SDG 3 on good health and well-being, as well as SDG 9 on innovation and infrastructure. Investment in cancer awareness, radiation technologies, and medical physics is ultimately an investment in human capital and long-term societal resilience. I encourage all participants to reflect, discuss, and deliberate on how the insights shared today can be translated into national strategies, strengthen regional collaboration, and actionable OIC level initiatives. I wish the seminar every success and look forward to constructive discussion and meaningful outcomes that strengthen cancer care across OIC and African region. On behalf of OIC Comstech, I would like to thank all the participants and organizers for their very valued work. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Thank you so much. I'm really thankful to the Coordinator General of OIC Comstech, Dr. Iqbal Chaudhry. Before I start the proceeding, I will say that I'm very fortunate today holding this webinar in the week of the Global Cancer Day in February. And second, the two speakers which are here today is my very former students in the initial day, and they are the mentors now. And I'm lucky to have them here as a mentor. So first of all, I will be glad to call upon Dr. Nadeem Abbasi for his lecture today, which is on the radiation therapy technologies and strengthening medical physics capacity. Okay, no, I will change to Nadeem Abbasi. Nadeem Abbasi's today topic is advancing cancer care and early detection strategies in OIC countries. First of all, I like to introduce Dr. Nadeem Abbasi to this forum. Dr. Nadeem Abbasi did his fellowship from Royal College in 1996, got CCST from UK and Ireland, and he is education chair and professor of radiation oncology at the Ahan University, Karachi, Pakistan. He is serving and served as a consultant in UK for 8 years, trained in the world-renowned Royal Medicine, London and Christie Hospital, Manchester. I am delighted to announce that and to tell that he is an author of 20 books and 20 papers. With this, he has a citation of nearly 1400 points with an HI index of 14 and I index 110 index of 28. Professor Abbasi is also a IEA trainer, trained 32 doctors in Bangladesh in 2014 and 2015. PG exam experience of the College of Physician and Surgeon, Pakistan, Royal College, and Turkish Board. Conducted workshop on leadership skills and professional development of doctors with innovative academic portfolio. Delivered invited lectures nearly in about 16 countries. And we are lucky to have him today, and I am also lucky to see him after so many years. Thank you, Abasi. Thank you so much for joining us and delivering your mentorship lecture today. Thank you
Thank you.
so much.
Thank you, sir, very much. First of all, I wish to just ask you, can you all hear me clearly? Because I'll try to speak as loud as I can. Can you please tell me, can you hear me clearly?
Yes, we do.
Okay. If there is any problem with our voice, please let me know. First of all, Assalamu alaikum wa rahmatullahi wa barakatuhu to our teacher, Sayyid Javed Khurshid Saab, and to all participants today, and to our director of Kiran Hospital, Dr. Asghar Hussain Asghar. Assalamu alaikum wa rahmatullah.
Wa alaikum salam.
Okay. Now, Bismillah ar-Rahman ar-Rahim. Today, actually, what I'm presenting to you, I would be grateful to my teacher and very respected our Sayyid Saab, Sayyid Javed Khurshid Saab, who has a great, contribution in Pakistani cancer care, in nuclear medicine, and also in radiation oncology and clinical oncology. So we are all his students, and I'm so happy to see that he is working so hard, like a young man when maybe he was 20 years old. So we are inspired with him. We learned a lot of things from him, and we will be inshallah learning more and more. So my first thing is the shukr guzari, the thanks which is due for you. So
Thank you
I
so
will
much.
just
Thank you so much, and I'm really happy.
so what I would request you, sir, because here they are providing me with a separate silent lounge for this meeting. I'm at the airport in Lahore, so I would like to have only 5 minutes, less than 5 minutes, to go inside that lounge. So can you please continue in the meantime to tell us? I will be hearing only. I cannot speak, but I will be hearing the real purpose for all participants, for all of us to be here. Only 4 minutes
Okay.
I will take to go inside the quiet lounge. They are very
O-
kind people. They were looking at me and they were saying, "No, please, you come inside." So I'm going inside.
Okay.
Sorry
Okay,
about this.
fine. Thank you. With this word, I will say that
Please,
in my life, I tried a lot, and I had a love to develop awareness in cancer treatment and therapy, and I'm lucky. उनकी आवाज बंद कर दो उनकी आवाज बंद कर दो and I'm lucky. Thank you, Nadeem, giving me a chance. I will take 4 minutes. In the meantime, you can reach to the lounge. And now I will start that I'm really lucky that I am the pioneer in one of the development of the cancer hospitals in Pakistan, and nearly 9 cancer hospitals has been developed by me. And see, my mission and my vision, my mission is to develop awareness so we can control cancer in the early stages, and my mission is to develop as many facilities in Pakistan, so we there shouldn't be no waiting time for the patient, and the machines and facilities will be always ready to provide this help. Second, this cancer treatment is so expensive that first of all we have to spend a little money in developing the awareness in the people so they can reach the facilities in the time, and second they get the treatment at time. So awareness is one of the corner stone in thinking and vision to be visionary in providing the facilities to the patients. And I'm lucky that today I got two renowned speakers, and with them we will sit together. I think we will develop a forum of OIC information center or forum to provide the insight to the other OIC countries. If they have problem, they can join, they can send their patients' detail, and you and other doctors on this panel will provide the help. This is my ultimate desire, ultimate goal in the life, to provide as many facilities as in the thinking and facilitate that the people to have diseases control. Thank you so much for this comment. And I think that now you must have reached the VIP lounge, and from there we can join you. And if you want, we can display the your presentation from here, or Dr. Asghar is already ready to display the presentation. I think now we can start. Dr. Nadeem will be now
I'm
in
ready.
launch.
Yes,
Okay.
I'm well settled and thankful to these guys. They are very nice people. So please, Bismillah Rahman Rahim. As we have seen in the cancer, I will humbly request you to put the slide on, or Dr. Asghar can.
I think they will
तुम
do.
कर दो. तुम कर दो.
Now, this is more than a presentation. This is more of an interactive session where everybody has equal right to stop me in between. Or if you have questions, you can write it down, please. Because today I'm going to show you some very important authenticated data as well, which you may have to write. And I will be requesting our teacher, Syed Javed Khurshid Saab, to share my slides with all the participants today. There is no copyright, and you can show it to your other colleagues as well, anywhere in the OIC countries. You are very welcome to show my slides. There is no problem in that. So, as you just to emphasize what I'm trying to say is the promoting cancer awareness and
Allow
advocacy for
us,
radiation therapy.
Dr. Nadeem, do
Sorry.
you allow us to put this on the web too?
Please, why not? I'll be so
Okay.
happy because this is all very important data, which it took me a lot of time to actually get it for you. It has IA data authenticated, all the references are there, and you may quote this data wherever you like. And there are some of my own summing up of which you can use for any country of the world, not Pakistan, but
Thanks.
any country of the world you can use. So it's promoting cancer awareness and advocacy for radiation therapy technologies and medical physics in OIC country, because this is our weakest link. You know, strength of a chain is determined by the weakest link, and our weakest link is radiation technologies and clinical medical physics. I tried to work on it, and today I am going to show you how much shortage we have of equipment as well in terms of hardware, which is again a very important thing. in the cancer treatment. So this first slide is okay, and then inshallah we'll go to the second slide, please. Disclaimer. Yeah, I have to actually just disclaim that with this presentation, I have no financial, things attached to it, or no gains, no advantages. But it is all sharing with all the colleagues so that they can use it for education and academic purposes. So that is a disclaimer from my side. I have no conflict of interest. And further disclaimer is that because I am very much biased towards the National Health Service in UK, because I stayed there about 15 years, so most of my mindset is from UK, because that makes a difference. Because in oncology, we have two different type of uh, methodologies. One is American and one is British or European. So because I spend a lot of my time in Europe, where I still go and I take exams, and I'm Royal College examiner as well. So that is again put me in a situation where I'm talking more in terms of British systems. But then since the last 20 years, I'm in Pakistan. So in Pakistan, we ourselves with the my team member is Dr. Asghar Hussain Asghar as well, who is going to give the second talk from Kiran Hospital. He's a director, which is a very responsible position in Pakistan Atomic Energy Commission. So he is going to tell you more about this as well. And again, ASTRO is the European Society of Therapeutic Radiation Oncology. Then IEA, you all know, it's in Vienna, International Atomic Energy Authority agency. Then we have Quattro, which is our radiation oncology quality systems. Pediatric Radiation Oncology Society, and Asia Middle East Society of Therapeutic Radiation Oncology. We all actually play a very major role in terms of leadership in all these areas. So this is my disclaimer. Next slide, please. So just to make life easy for all participants today, so that they will understand the whole concept very clearly and they can teach these concepts to their juniors and their colleagues. So three M's. First one is manpower. Now it does not mean that women don't have a power. So that is why we say person power. So that it's not gender bias. So manpower means person power, where men and women both work together actually and try to help the patients. Number two is the methodology. So methodology is our way we work with quality. And number three is the machine and material, very important in radiation treatment. Machine becomes very, very important. And today I'm going to give you the statistics of all IA for international countries, how much machine is short. Linear accelerators are short in our countries. I'll give you all the sums. You can take it and you can open the sources of IEA. The references are there. So all these three will be my main topic of today, which will cover the quality: manpower, methodology, and machine. Next slide, please. So manpower, because women power is important as well. Sometimes it's more important than the manpower. So especially at home. So in order to avoid any gender bias, I'm using the word person power. So human resources is the most crucial and important resource of any system. We have to look after our working colleagues with the theme of caring, the carers of the patients. So for me, my colleagues are very, very important. The talent which you will see in OIC country is phenomenal. So great talent is there, expertise is there. If we have to utilize it properly with the teamwork and collaboration, we can achieve anything we like. So manpower is the most important thing, which is a human resource. So please, if you have any questions, write it down on a piece of paper. I'll be happy to answer it at the end of my talk. Now, number two, please. So when we say the word skills, we only mean professional skills, and that's where the problem comes. And that's what we are going to learn today. That it is not the professional skills which is important, it is the leadership skills which is equally important, if not more. I would say it's more important, but anyway, I would say that it is the one skill which is going to rule, which is going to tell us whether we can use our professional skills or not. So nobody can say that this skill is lesser important. Nobody can say that. So that is why, please, whenever we use the word skills, we actually mean two skills. One is our professional skills, like many of you today are related with radiation oncology. Some of you not related with radiation oncology, but with other fields, whatever profession we have. If you are medical physicists, if you are technologists, if you are administrators like sir, everybody has a leadership role. Like our Iqbal Chaudhry Saab has a great leadership role which he is exhibiting. Our Sayyid Javed Khurshid Saab have a very special leadership role. So everybody has a leadership role, and professional role is important, but leadership role is going to make the change. So that is my message for you to take home, please. You can ask me any questions with me afterwards. And next slide, please. Now, the professional skills, the theme is that whatever we do actually has to be of a high international standard and quality. So, doctors are the main carers of the patient. Doctors can be consultants and PG residents. Then comes the clinical medical physicists, who actually are the CMPs. Then come the RT technologists, the radiation technologists, who actually treat the patients at the machine, which is linear accelerator or cyber knife or gamma knife, whatever we use. And the fourth one are the clinical engineers, very important. I'm sure in our audience today, there will be some clinical engineers as well. Previously, we called them biomedical engineers, but nowadays we are calling them clinical engineers. So this is what comprise of four things which makes the high quality radiation oncology service. Next slide, please, sir. So what is CMP? CMP is not an ordinary medical physicist. He or she is the medical physicist who is involved in the clinical work. So we have to change this term, and Pakistan is the first country which is actually advocating this change. So I request all colleagues who are not from Pakistan today in our gathering learning session, I would very humbly request them to start using the word C in front of MP in order to have the right human resource available to us. So it's a CMP, clinical medical physicist. Thank you. Next slide, please. This is where actually I'm trying to show you that when we do any technical work, we publish it. So, and our colleague Dr. Asghar Hussain Asghar, he also publishes a lot. So, let's see in this publication, this is a publication which is cited by 102 papers. So, just imagine that how great impact it has. And this is originated from Pakistan. Our colleagues, very young colleagues, have done this paper, and that is about the radiation treatment with a skin surface dose. 102 is a very big number actually. That means that 102 uh, researchers who put when they put their paper for publication, they were have to give our reference. They were bound to give our reference. This binding is important. So that is shows our standard of publication in Pakistan. So I'm very proud of my team who are publishing. You can see my name is right at the end. So main are the youngsters who have done this effort and published. Next slide, please. Then again, we all do errors. None of us is mistake free. We are human beings. To err is human. So we have to do some errors. But we don't come out and tell what errors we have done. Now, my colleagues were very brave, and whatever errors they have done, they have published it internationally. So anybody can learn from our mistakes because we do mistakes. So mistakes are the best teacher. Mistakes can tell us more in radiation oncology and radiation therapeutics. So mistakes are very important. So I would request all of you that please in your clinical practice or whatever practice you are doing professionally, please document your errors and tell everyone that you have done these errors. And next slide, please. And And whatever we do, actually, we have to discuss it in the boards. Now, boards don't all belong to doctors only. You can have boards with multidisciplinary, with different multiple disciplines. So MDT stands for, as you all know, multidisciplinary team. MDT. So this is the name of the game. This is the catchword. This is what going to happen in future. Next slide, please. This is my own department's research, because most of you are in research, and I know you'll be publishing a lot. Our Dr. Chaudhary Saab, Professor Chaudhary Saab is well known for his research, especially what he has done with Professor Atar Rahman Saab. Everybody knows that. So for that, I'm just proud that we have done more than, as you can say, 3,000 citations and about papers which are 800 plus. So we are proud of our students. I put all the students' names there. I'm only one of them, but 22 students who are working or worked with me. Next slide, please. And then our boards, which we have done. So all of you are a part of a board. Every single scientist, whatever the specialty or profession he belongs to, is a part of a team. So that is what we are preaching, that we should have a multidisciplinary board where we'll be discussing our cases, especially difficult cases. So next slide, please. Yes, next slide, please. Okay, can you hear me? Yeah. Now this is very important slide. When we come to bring a case to the department, we have to do a peer review process, which has to be 100%. So if I'm bringing 100 patients I'm treating, not 99, no, 100. All of them have to be discussed with all colleagues. This is called the peer review process. Alhamdulillah, we are the pioneers in this country for this process, and we are, Alhamdulillah, discussing it with everyone. And we are trying to publish on it so that the whole world will follow us, and we can learn from each other. So, other country people are here today with us. I would humbly request them that they are very welcome to contact me or Dr. Asghar, and we'll be happy to guide you and assist you, inshallah, and collaborate with you if you want to develop peer review systems in your department. Next, please. Now, the impact of we have published. So, somebody can ask you why we are wasting time for peer review. So, this is the answer. You can see that it is the experience sharing which has an impact. Okay, next slide, please. Workflow on slides, workflow. COVID-19 workflow, we actually have published that. That's a paper you can see. Our authors published it in Turkish Journal of Oncology. And there we have proven that there is an impact on workflow. So we are very, very careful about the workflow. This is our weak point all over the world. Wherever you go for radiation treatment, there is always a waiting list, and we have to handle that. Okay, next slide, please. Now, the second set of skills, as I said, is what? It is the leadership skills, which we have to learn from our mentors, seniors like Iqbal Chaudhary Saab and Sayyid Javed Khurshid Saab. They are the role models. So we have to learn from them. So I actually tried to put it in perspective, and I tried to put it in such a way that it is organized and structured. So next slide will show you a list of 20 skills. Please, next. Okay, 20 skills. Can you see those 20 skills very clearly? All of you? Now, I'm not going to read all those 20 for you. You have done these courses and workshops, different piecemeal, at different occasions. What I am doing is that I'm doing it in a structured way. So I'm trying to teach people and telling them all these 20, you know. So that is my humble request to all of you, that in your departments, in whatever country you belong to, whichever institute you belong to, whichever city, please introduce these 20 skills teaching. They are extremely easy to arrange. You can even arrange them free of cost through your management sciences people, or business schools, or even the YouTube, through the YouTube. So it can be a self-learning process. You can learn them. Next slide, please. Now, there are three aspects of human development, and all three aspects we have to address. Next, please. Okay. What are those? That we actually have to have a mentoring system. Then we have a leadership skill development, 20, which I showed you. Then international networking, which is today. Today, what we are doing, trying to do is international networking with the platform of OIC. Then comes the national, which we do in our own countries. So if you belong to any country, I was in Bangladesh just 1 week ago. I stayed there about 7 days, and I've done a lot of national work for them. And I went to UAE after this. So national working is very, very important. For us, it's international, but for those who are working in their own country, it's national. Then tumor board, as I said, 100%, and peer review 100%. So that's our campaign. Now 200 linear accelerators are short. I promised Sayyid Saab, our teacher, Sayyid Javed Khurshid Saab, that I'm going to give the real statistics today to all of you who have spared their time today and came all the way to attend this. So it is my responsibility to give you the data which you can use further yourself. Okay, next slide, please. So this is one of the projects which was requested to me by the Italians, that they want their residents to get training here. So we call them, you can see release 1.0 and release 2.0, and we trained their doctors. We are training many people from outside Pakistan, and I welcome all of you who are not from Pakistan today, that you are welcome to contact us, and we'll try our best to assist you in terms of teaching and training, and which we have done in the past as well. Uh, this is one of the example. There are so many examples, but today, because of the time, I'm only showing you one example only. Next slide, please. Now, these are our two Italian colleagues. I went to Rome, and then one is a Pakistani, and then they got training, and now they are in faculty positions, and we're grateful to us for their Pakistani training. So it was their request, and we fulfilled their request, inshallah. Alhamdulillah, and we got very good results. They're very pleased, and they got good progression in their profession, in their career. Next slide, please. Now, this is another very important aspect which Sayyid Javed Khurshid Saab is very much concerned, and that's most of his time in his career. He was very much careful about these ethical practices. So, for ethical practices, we have our own assignment. This is available on the blog. Anybody can download it, whoever wants to fill it up and do it. As an assignment, you can give it to your students and to your colleagues. So this is all available on the blog. This is another very important aspect which in OIC we require actually. OIC must adopt some systems like this. We'll be very happy to assist, inshallah. Next slide, please. Now, this is our slogan and our books. This is our three books on this topic. And today is one of the days when we really have to make sure that we take this message home. We take this message home, inshallah. Okay, next slide, please. This is our Global Village Oncology Network. That's again available on the web, and we are publishing about this as well. This is multiple countries involved in it. At the moment, the Canadians actually are with us. We are the ones who pioneered that. We started, we initiated, and we brought the concept. And then many countries have joined. So it's a Global Village Oncology Network called Chivon. Next slide, please. Another publication where we are very much keen that we don't want exam passers, the people who just come, get memorized things, books, and then pass the exam and try to get, different positions and offices. No, we don't want that. Actually. We want carers of the patients and those who take this specialty further up and which are proficient radiation oncologists and clinical medical physicists and RT technologists, radiotherapy. The whole therapy components have to be learned for the sake of patient care and for the progression of the profession in the country. And that's exactly what we are doing since the last 20 years. Next slide, please. Now, this is very important because I promised Sayyid Khurshid, Javed Khurshid Saab, that I'm going to give the data. Today is the day of data. Everybody wants data. Everybody wants evidence. Everybody wants to update himself or herself. So this is the facts and the figures. And I've targeted Pakistan, but any country can easily get it through the net. There is a way to do it, and you can easily do it. So, Atomic Energy Commission has links with local atomic energy commissions. Pakistan is a very leading country when it comes to uh, Atomic Energy Commission education. We are some anchor center like Noori Hospital, Islamabad is an anchor center for IEA, International Atomic Energy Commission. So that is why we are proud of our findings. So this is the finding I am sharing with you with the hope that you will take it further. And inshallah, for your own countries, you can get these three facts and figures like I did it for my own country, Pakistan. Next slide, please. Now, there are global shortage of 5,000 linear accelerators, the main backbone machine of radiation oncology. Just imagine 5,000, not 1, 2, 3, 4, 5,000 are short across the globe, the whole world. Now, we may say, though, okay, we don't mind what is happening in the whole world. We want to know our own problem. Okay. Next slide will tell you that problem. Now, we are not one country. We are getting patients from Iran, from Afghanistan, all over Middle East. Recently, we got a patient from Somalia. Sometimes we get patients from Sudan. You name it, actually. Everywhere people come and get treated. Malawi, Madagascar, Kenya, Tanzania. So we have to calculate our numbers with the regional countries in mind, not only Pakistan. Next slide, please. If we will not give radiotherapy in time, if we don't have machines, if we have long waiting lists, if there is an accessibility issue for the rural patients, even for the urban patients, if there is money barriers that people don't have money to pay, what is going to happen? Can you see the list of cancers on the right hand side? Breast cancer, uterus cancer, cervix, colorectal, lungs, non-Hodgkin lymphoma, ovary, pancreas, stomach. They will not be able to survive. So it's a very, very important factor to keep in mind that we are the lifesavers. We are saving the lives of the human beings, our fellow human beings. So that is why it's very important, very, very important that we understand this. So my very humble request to you, all of you, that please take this message home and do your best to increase the facilities of radiation therapy technologies all over the world, especially in your own countries, wherever we are, we have to increase it. And this is the evidence. Next slide, please. Now, the solution does not lie in one linear accelerator. Sometimes people do this wrong actually approach and they put one linear accelerator. We are totally against that. Dr. Asghar Hussain Asghar will tell you more than me because he treats more patients every day than me. I treat less. That you need actually two bananas. You cannot have one. So twins. You can see a beautiful picture of two children who are twin. So we need twin Linacs. Whenever you buy Linac, buy two. Linear accelerators are the main machines for the treatment of cancer. And if you have a department, please do not have one bunker. Try to have two bunkers and put machines which are identical. Maybe not from one vendor, they can be from two different companies, but their specification has to match. That is why I'm using the word twinning. Twin is the word I'm using. Okay, next slide, please. We need 200 plus Linux in Pakistan. So 220 is the number I got from this table. You are welcome to actually go for this publication of IEA, International Atomic Energy Agency. But remember, this is for low income countries. We consider Pakistan as a low income country according to the WHO classification. So that is why we need only 200, 220, but I made figure 200, which means that 100 pairs. Because as I said, you are not going to buy one Linux alone. It has to be in pair always. Now, this has given high resource countries as well, medium resource as well, and low resource as well. Like, for example, Austria, France, Ireland, Italy, Malta, UK, United Kingdom, Spain, Netherlands, Holland, and then medium countries like Hungary, Latvia, Poland, and low like Armenia, Bulgaria, etc. Anyway, Pakistan is coming in low middle income country. So we have calculated that we need 220 linear accelerator in Pakistan. Next slide, please. Now the problem is that what we need today may not be the need in 10 years time or even in 5 years time, because what machines I'm using today, they are already old. They are going to die. It's 10 years is the half life, sometimes 12 years they say. We have a linear accelerator in my department, which Alhamdulillah is working fine, and we are using it like anything, like a donkey cart, we say. And how many years? 20 years completed in February. This February, today is the 14th of February, 20 years completed. Next slide, please. In Karachi, because I belong to Karachi, but every city has its own statistics and every country has its own statistics. We have 8 radiation oncology treatment facilities where radiation treatment is given. And there are 7 who are thinking to start. When they say thinking to start, I know that Indus is going to install soon, Liaquat National installing soon, and third is Shaukat Khana Memorial Hospital, Karachi branch, starting soon, and rest uh, will come on board as well. So this is the situation which I displayed to you in Pakistan, in Karachi. Next slide, please. Now, from where these 200 electors will come? Number one, Pakistan philanthropy is very strong, as you all know. So charity sector is one of the best in Pakistan. So that comes as number one. Then come the private investors, because as you know, there's a lot of installation charges. It's an expensive equipment, but although break even becomes very easy, many private investors have put it in Pakistan and Bangladesh and India, and they got their not only money back, but they have expanded. Then come the trust hospital, like all I personally also work in a trust academic university. Then come the donor consortium, international agency, like Atomic Energy Commission gave Linux some time to people in different countries, then governmental, and any combination of the above sources. So there are only 6 sources, to be honest. If you have a 7th one, please let me know. And those 6 is going to, intermingle and see which one is required where. So any model of running the linear accelerator can be considered fully private or totally free. So this is 1 and 3. What is number 2 is the Robin Hood. Robin Hood was the one who used to rob. He was a Robin the robber. And his robbing was to the more filthy rich people, get their money, but by night time he used to give it to poor people. In our language, we have the similar character called not Hatim Tai. Hatim Tai was very generous. Sultana Daku. So he is the one actually who takes this money and give it to them. So that is why we have another model of totally free. We have Cancer Foundation Hospital model where they take money from some and don't take at all from some, depending on their financial status. And then partial welfare cover, gradual self-sustained model, and endowment. We have in Pakistan also we have endowment. I know in many countries like Malaysia, Indonesia, these OIC countries have an endowment. If you have an endowment, that will become life very easy. Next slide, please. So a focus group is formed already in Pakistan, but I request humbly or to other countries to make this group. We can collaborate. We have leadership people like Sayyid Javed Khurshid Saab. He can inshallah help us. He can guide us. He can mentor this focus group. So focus group is very important so that we will not get distracted. Next slide, please. So this campaign is very important. We have to join this campaign, which is of 200 linear accelerator Pakistan requires today. This is the whole slogan. We require 200 Linux today. That's our campaign. Going on, my blog address is there. My blog has a lot of information for anybody who wants it, any faculty, student, a lot of academic work. Our papers are there for trainees. Please feel free. And my email is there as well. Here, actually, I will be requesting our sir to please just let me stop. And then, if you have any questions, people have written down during the presentations. They are welcome to ask, and I'll be very happy to answer them one by one. And any slide you want me to run again, I will be happy to run. There are 37 slides. This is the last one, and it has the blog address, and you can see it has the email as well. So I can see there are so people from so many countries, and they all have a right to ask. So maybe with your permission, sir, may I stop here? So you can
Okay.
inshallah carry on from here. I'm muting now, but whenever you say, I will unmute myself. Okay, thank
Okay.
you, sir.
Thank you. Thank you so much. First of all, I have a question for you. Because see, you see that this seminar is also, and what we are doing is for the African countries and the countries which are least developed. So in my times, we often used to think that Cobalt 60 as a workhorse. So I know it is a very old machine, but what do you think that it is a very strong and hard machine to very easy to handle? What do you think that in the African countries we should give Cobalt 60 a portion of the treatment to? This is my question. Are you hearing it?
I hear very clear. I'm muting myself. Very clear question. Sir, this question is asked from us all over the world in many, many places. And we try to answer it, Dr. Asghar also. We have to be very careful about understanding two things. One is the cancer patients who can be cured and the cancer patient who cannot be cured. So there are two distinct intention of treatment. One is radical curative and the other is palliative. Palliative means if somebody is having a pain in the bone, you give some radiation, the pain will go. Somebody is having blood in urine, you give some radiation to the urinary bladder, it will go. These are simple things. For that, yes, cobalt can be used today in poor countries, but it is an obsolete machine in the West and in many countries. In Pakistan also, we are now into linear accelerator long time now. So I think because OIC has to move forward. If you have to move forward, then we have now cheaper brands of linear accelerator available, which are not that expensive. So we can have single energy, for example, in
Question
Pakistan,
पूछ रहे हैं
many
दूसरे
places.
लोग हैं
So, but
क्वेश्चन
I think no more buy a cobalt, please, because otherwise it is too old. Even technology gets so old that you will not have operators for that, and it is a hazard for radiation protection, which is your a lot of your work which you have done in your career, Professor Javed Khurshid Saab is on radiation protection. So just imagine how difficult it is, in cobalt. So I stop here. Then I let you speak as a senior, please.
Thank you so much. Is there any question from any other side? Mumtaz, do you have any questions? We don't have any questions, and that was my question. Due to reason, I know that linear accelerators are the best, and we you know for how many linear accelerators I have gone and my thinking. But when you talk about the African countries and the countries which is still don't have the cancer facilities, so I was thinking to have your comments that whether we can start there for the machines like Cobalt 60, which we can easily get from other countries, or the machines which are absolute and like some countries like to donate, so we can put them in OIC countries. This was my concept of thinking about the Cobalt 60. So in that way, we will provide some of the facilities and can guide them instead of if we don't have the money and the OIC countries don't have the money, so they can have a little some of the little facility or some of the facility which we can start with. This was my question actually. I know this is an absolute machine.
Yeah, sir, nowadays the linear accelerator is not as expensive as it was 20 years ago or even 10 years ago, because they have so many models and they have consortiums. As I said, IA can help, because if you are going to put money, it's a matter of little bit more money, but have a good quality treatment, because we should be curing patients. It's not palliative. Now, just to address your issue, for example, in an African country, you have two linear accelerators. Fair enough. The third machine can be a cobalt. It's a
Okay.
workhorse. I agree with you. Okay.
Okay. Thank
And
you
that
so
will
much.
take care of the palliative. So I think this is one of the solutions which I can give you.
There is a question. Can you display that? You can look at it, or I have to read it. Dr. Abbasi, can you read the
I
question?
will be grateful. Please, if you read it for me, I will be really grateful.
Okay, okay,
Please,
Mumtaz, can
please.
I see? Can you display it, Mumtaz? पढ़ जरा दिखाओ बड़ा करके तो आई कैन रीड इट. ओके, कैसे रीड करूं?
मैं पढ़ देता हूँ
Okay,
सर.
I'll read it.
ओके
I'll
ओके
read it. Okay, no problem. Dr. Asghar, I'm reading it.
Okay.
So, do you involve clinical pharmacists to identify pharmacovigilance during radiotherapy? At this moment in time, it is the medical oncology colleagues. Don't forget, all of us, like Dr. Asghar Hussain Asghar and myself, we are all clinical oncologists. So we know how to give radiation and we know how to give chemo. So in chemo, actually, we have the pharmacists working very closely with us every day, and they are the ones who actually make it for us. But when it comes to radiation, up till now, it is not something which is in a routine day to day clinical practice. But I hope, inshallah, that is a step forward when we'll be getting them on board. Now, coming to all the medicines which we use in radiation, of course, they are fully approved and discussed with the pharmacist, always, not without this. So that answers your question, or you want more clarification? Please let me know. You can put it in the chat.
With this, is there any other question? I think I thank Dr. Nadeem Abbasi for a very insightful lecture, and I'm humbled mentioning me in few of the things, and I will try to do my best for still I can do something. Thank you so much. With this comments, I like to invite our second speaker, which is Dr. Asghar Abbasi. First, he will be delivering a lecture on the radiation therapy technologies and strengthening medical capacity. I like to introduce Dr. Asghar Abbasi. He is a seasoned consultant, clinical oncologist affiliated with Kiran and Mehman Medical Institute at Karachi. With over 25 years of experience, he specializes in the management of all cancer types. He holds a master's degree in nuclear medicine from PIAS and FCPS in radiation oncology. a founding member of City Tumor Board. He is also a supervisor and examiner for CSP and regularly facilitating research methodology workshop. Dr. Asghar actively contribute to the national and international oncology forums and is a motivation speaker for PAC. He is a member of ESCO, ISMO, FARO, PCSO, RSP, and PMA. In 2016, he received a gold medal from Pakistan Atomic Energy Commission for his outstanding contribution to the oncology. Now I leave the forum to Dr. Asghar to give his presentation. Thank you, Dr. Asghar.
Thank you, sir. Thank you very much. Can you hear? Hello? Hear
Yes,
me?
yes.
Okay, sir.
Yeah.
My name is Dr. Asghar Hussain Asghar, and I'm working as an oncologist. I'm audible to everyone? Is it okay?
Yeah, it's okay.
Okay. Thank you very much, Sir Khurshid Sahab. You are a teacher, you are my mentor also, and I know you very well, and you are quite academic interest personality, and you love to teach and you love to run such type of academic events also. And this is our first interaction with you on from the OIC forum, and I think we'd like to continue this activity in the future also. I had the two presentation. Initially, I will tell you some international data and where we Pakistani people stand in the international community regarding the cancer statistics. And then there is some advanced presentation on what radiation technology has improved now and how we can move forward. Cobalt 60 is almost obsolete now, but we were trained, we worked with on the Cobalt 60 machine. This was considered the working horse machine, but now if you can install just only 6 ME photon machine, also that work like just a Cobalt 60, and you can treat with the 3D radiation and even with this further advanced technology like IMRT and the VMAT. Before starting my presentation, for all those my international participants who are seeing us, I'll just show you what is the Kiran. Kiran is basically a Karachi Institute of Radiotherapy and Nuclear Medicine. This is a hospital which was started in roughly in year 1999. This is one of the biggest setup of Pakistan Atomic Energy Commission out of 21 cancer hospitals in the whole of this Pakistan.
Asghar, can I say something here?
Sir, please, yes, you can.
Okay, we have inaugurated, and I was the person who there in 2021, and I'm happy to see the center now. So beautiful. So I inaugurated.
I show you this hospital which you started at that time, and this is the Kiran Hospital. This is a drone shot view. This is the Kiran Hospital and Karachi Institute of Radiotherapy and Nuclear Medicine. I just stopped it over here, and this is the first phase, sir, which you started at that time in 1999. And this is roughly of 18-acre machine area hospital. On the behind this side, this is the Dow International Medical College and the Dow University Hospital. And if you just move forward, this one furthermore, and this is our phase 2. In this phase 2, we have this ward block and daycare setup of the chemotherapy, and we are treating roughly 150 cancer patients with the chemotherapy per day, and almost 230 to 250 radiation machine fractions per day in this one setup. And we have now 5 linear accelerator machine, and we're treating at quite nominal rates, and the poor patient getting free of charges treatment. And our target is to treat 500 patients per day on these 5 different machines. So all these machines are installed in this one setup. And if you just see further, this one is this is our second phase with the auditorium, radiation and blocks, and this all indoor wards. And on this left side is the Mayman Medical Institute. This is the cricket ground of the Dow International Hospital. So all this is in one setup. This in one setup. Just 1 minute. Okay. So This area is a almost a medical hub of Karachi, where you have the general hospital, two big general hospital, and one cancer hospital in between. So this is a setup, and I just start now with my presentation. And another presentation, I just start the new one. So if you just see, sir, this one, this one.
इसके टॉप पे ना यहाँ का भी दिखाओ और फिर तस्वीरें खींच लो इसकी टॉप पे खींचो मैं
If you just see hiding photo. Sir, this is a cancer statistics. Basically, this was not my topic of today, but when we saw the most of the people have interest in this initial cancer statistics, where we stand in the field of cancer in Pakistan. Pakistan considered to be having the highest number of the cancer patient in this southeast east region. But if you just see over here, where we stand, I have nothing to disclose in this my presentation. Our world statistics say that almost 19 million new cases are diagnosed every year in Pakistan, in this world, and 10 million are expired. But what is the statistics of cancer in Pakistan? I'll just show you. If you just see, roughly 27,000 cases are diagnosed and have an expiry rate in per day in the worldwide. Mean 27,400 patients get expired in 1 day in the whole world. And if you just see, this statistic go roughly 19 patients per minute, while the cancer expiry from this cardiac event is roughly 34 in per minute. So we are the second in number, that the cancer mortality is second in the world after this cardiac event. But definitely cardiac events are quite high because due to multiple reasons. Cancer should not have been so high. In our third world region, there is a second another cause of mortality in this area, some infectious disease. People here in Pakistan expired due to some infections like diarrhea, like in form of chest infection, all these things. So here we have the second one is insulin, but overall in the world, after the cardiac event, cancer is having the highest mortality. And if you just further titrate this all this thing, if there is one death due to breast cancer in the world in 1 minute, which is quite high. Mean breast cancer is the highest in the world out of total cancer diseases, and this mortality is going up to one cancer death due to breast cancer in per minute in the whole of the world. So this quite alarming situation. But if you just see what happened in with the COVID-19, COVID-19 there was total 219 million cases were reported in the COVID-19, and expiries were roughly 4.5 million. This ratio goes up to roughly 2%. But if we just see over here in the case of cancer statistics, out of 19 million, 10 million expired. Roughly 50% of the patient get expired, but we don't have a good campaign against the cancer in the whole world. We worked a lot for this lethal disease for COVID-19 at that time with good media campaign and all these things, and we controlled it very well. But we are not doing anything much better in this case of the cancer, which is the second common cause of the death in the world. So this is my message to all of this country who are listening this my presentation and seeing this my presentation, that this is an alarming situation. We'll have to work for this cancer mortality also, as we did for the COVID also at that time. So I have collected this data from the IARC, from Global Cancer Observatory, and all these different sources. And I have collected this one. The China is having the highest number of the cancer in the world because of this, because they have quite high, big population. Then the second one is the United States, and then India. So out of these top 10 countries, Pakistan is no more there. But it doesn't mean that we are not having the cancer patient. We are receiving so many cancer patients as per the population. But definitely all these three countries have quite big populations. They are getting total number of more cancer patients as compared to the rest of the world. But if I'll show you what's happening in Pakistan. Most common cancer in the world is definitely lung cancer. You know it very well. In the case of the male is the highest number, and then almost same number is with the prostate cancer. So these are the two lethal cancer. But out of these two lethal cancer, lung cancer is not so. Lung cancer is definitely more lethal as compared to prostate cancer. And if you just see this red bar is showing the mortality because to with this lung cancer. If you see, it's more than 50% of the mortality out of total incidence of the cancer, lung cancer. But if you see in the case of prostate, it's quite less number of mortality as compared to the incidence. So prostate being the highest number in the world after this lung cancer, but it has a good treatment regime available by which you can control the prostate cancer very well as compared to the lung cancer. So lung cancer is considered the lethal disease. Prostate cancer is considered somewhat lethal disease, but not so significant. So we can have a patient of prostate cancer even with the stage 4 disease can have a survival of 2 to 3 years more than that. So in this way, if you just see, there are many other cancers which are quite lethal. I'll just give you the example. The liver cancer, hepatocellular carcinoma, is the more common in this region of Pakistan, is having the quite high mortality also in the world. All. So it doesn't mean that we don't have the good facility of the cancer treatment in Pakistan. Liver cancer is itself quite lethal, and we don't see that the liver cancer patient have a good survival. Same way, gastric cancer, stomach cancer is also quite less survival. But as compared to the other cancer diseases, we have like bladder cancer, we have the good survival regime. We can treat this patient. We can save the bladder without operating like radical cystectomy. We can save the bladder with the radiation and the chemotherapy. So this is a world experience, and this our experience also that in the world we are also having the same type of the consequences which the world is seeing. This is a picture of the male cancer patient in the world. And if you just see the female cancer patient in the world, like this is breast cancer is the most common cancer in the world and quite high incidence. Everyone knows that the female having the highest problem with this breast cancer, but Alhamdulillah, this is a well treatable disease. Well treatable disease, well controllable disease, even in this third world country where the people have quite poor awareness about this cancer, they are having they're being treated quite easily. Like if they're coming to us in the early stage, we can very well manage them. Even the stage 4 breast cancer patients also having the mortality quite less as compared to the lung cancer and all these things. So picture is almost plus minus same in the lung cancer in the female also. Cervical cancer, which is considered with quite high incidence in the European countries and the West as compared to this our region, they have also very good management technique and they come. Thyroid cancer considered the quite safe cancer, quite less mortality in the case of thyroid cancer, but this incident it is also there is in the top 5 countries, so top 5 cancer diseases. Same way in the case of uterus, stomach, and all these things. So if you just see the most common cancer like the breast cancer and the prostate cancer, which is a disease of some hormonal imbalance can be very well treated. But the disease with not having such type of, like in the case of lung cancer, which is most of the time due to smoking, is quite lethal. It's not a manageable disease, but it can be very well easily prevented. Like if you can stop smoking, if you can have a good smoking cessation counseling technique, then we can very well control the lung cancer also. So if you just see now, what will happen in 2040? In 2040, in the low income countries, there is a gradual increase in the cancer incidence. High income definitely is quite high. In the very high income, there's also quite high. But it doesn't mean that we don't have the ratio. If you just see the ratio, our ratio is quite high. In the low income countries, we're getting doubled from 0.65 to 1.27 in 2040. Our cancer mortality will be quite high as compared to this region. We're already having so many cancer patients. So we have to work for something in this low income countries at this stage so that we can have less number of the cancer patients in 2040. So this bar is showing quite less, but if you just see the actual figure, 0.65 is getting doubled in 2040. So this I've tried to show in this my presentation that in low income there is a 96% increase in the cancer in 2040. So it doesn't mean if the European countries are having quite high incidence at that time, we will be having the quite double number of the cancer patient in 2040. So we'll have to work for all these things at this stage. This I've tried to show in this picture in the form of presentation. In 2040, if you just check me, if you ask me what were the cancer statistics of the Kiran Hospital, we were seeing quite high number of the cancer patients of the head and neck region. Dr. Nadeem Basi is my teacher also, and he was my examiner also at that time. And he's treating head and neck cancer quite high in the even in the quite expensive setup of Vakhan Hospital. He'll witness that he's seeing so many cancer patients of oral cancer in this region of Pakistan. So only because this the hair is some bad habits of betel nuts and all these things, which is not so common in the rest of the world. So this is the region we're seeing so many head and neck cancer patients, specifically the oral cancer in this region. The second most common cancer which you're seeing in the current is the breast cancer in the female, and then colorectal cancer. This is a combined data of the male female, and this is colorectal cancer more common. Esophageal cancer is quite common. Hepatobiliary cancer, like specifically the hepatocellular carcinoma, and then the lung cancer. Lung cancer is quite less in our region. Even then, we have the quite high number of the smoking. But if you just see the most common cancer in this region is the head and neck cancer and the breast cancer. So in the breast cancer, if you ask me what is the statistics in the worldwide, roughly 2.3 million new breast cancer cases are diagnosed every year in the, worldwide. And out of this, roughly you can say 685 patients get expired. So in 2020, and it was just only 7.8 million alive cases, and which will show the prevalence of roughly 25%, and death rate is 15%. So we have the quite high number of the breast cancer in the world. The highest number of the breast cancer which has been reported in the world is in the Belgium. It's roughly 113 per 100,000 female in the Belgium getting the breast cancer. Same way in the Australia is 96. In the USA, it's 89 per 100,000. But if you just see in Pakistan, it's roughly 34 cancer patients per 100,000 as compared to our regional country, which is India. They are having the 25 per 100,000. So in this region looks to be quite high, but in as compared to our regional country, India, we're quite high number of the cancer, breast cancer patient, as compared to rest of the which is having quite high number. So you can say in this region, we are having quite less number of the breast cancer patient. But if you compare it with this, the other in the regional country with India, it's quite high. But we are quite low in number from the West countries. If you just see in the regional situation, India is having the quite number of the cancer patients because they have the high number of the population also, and their mortality is also quite high. Then is the Bangladesh, and we are in the third one, which is Pakistan. Iran and Kazakhstan and even Afghanistan are quite less in number as compared to our three countries. If you see the top 10 cancer in Pakistan is top 10 cancer is the female in the breast cancer, and in the male is the oral cavity and head and neck cancer. Then in the male is lung cancer, most common. In the female lung cancer, this year lung cancer quite less. Esophageal cancer is almost same in both male and female in Pakistan. Colorectal cancer more in male as compared to the female. Blood leukemia quite high in male as compared to the female. Gastric cancer is almost same. Lymphoma is more in the male. Liver cancer is more in the male, and the prostate cancer is the problem of the male. So we can see almost the most common cancer which is in the world are also there, except this one, oral cavity cancer, which is quite high prevalence in this region of Pakistan. And if you just see now how we can manage, our incidence of the breast cancer is 34 per 100,000, but if you just see our mortality is also quite high. As compared to the other countries, we are having the mortality is quite high, so we have to do some things to better control the disease. Same way in the oral cavity, we have the quite high number of cancer and mortality is also high. In the same in other cancers also. This is a new cancer statistic, and lip, lung cancer, and many of the other cancers. And if you just see, now I'm just going to show you the comparison from the regional countries. In the regional countries, this blue bar is showing the incidence of the new cancer patient in the breast cancer in the Pakistan, and this is of India. But if you just see, red bar is showing the mortality. So they have quite less number of mortality as compared to their incidence, but if you just see our red bar is also quite high. So it means our mortality is quite high along with the incidence of the disease. So our measures to control the disease, to manage the disease is also not so adequate as compared to the regional country. They have tried to control their mortality with the good incidence also. Same way, cervical cancer is more issue in of India as compared to our region, but their mortality is also quite high. So, Alhamdulillah, in this region, incidence and mortality of cervical cancer is much less. Same way, ovary and many other countries. So I just want to show you that in the region of in our region, in Pakistan is having high number of cancer as compared to India, and same way in this Bangladesh, we're also having high number as compared to this Bangladesh. Same way with Afghanistan, we are quite high as compared to the Afghanistan, and same way with the almost Iran mortality, but Iran has less mortality, so incidence almost same. So you can say in this region, Pakistan is having high number of the cancer patients as compared to our regional countries like Iran, India, and all this thing. And if you just see, if you just compare from the European countries and the Western, US is having quite high number. The incidence is going roughly more than 80 plus cancer patient per 100,000 of the breast cancer as compared to Pakistan, which was just only 34. But our mortality is almost quite high. Their mortality is quite less. So survival is quite big in issue in the case of this cancer management. If you have the good survival, not only if you're not being controlled, but good survival in the stage 4 disease, then it means you can have a better control of the disease. Same way in the rest of the disease also. If you just see from the Europe, they're also having quite high number of the European cases, breast cancer as compared to Pakistan. Now, I'll just show you some factor which you can see that which can increase the breast cancer is the growing age. With the growing age, we can see as the age go up, up to the age of 60 plus, it's 1 in 28 women get breast cancer. In same way, after 70 plus, 1 in 14 women get breast cancer. So it means age is a big risk factor. So overall death due to breast cancer is 1 in 8 in the female. Being a female is itself a big risk factor, and because the breast cancer, in the case of the breast cancer, but in the male, it's a big risk factor for the prostate cancer. Obesity, if the BMI is more than 30, we are at patients at high risk to develop the breast cancer because high BMI, high insulinemia, high risk of the breast cancer. So all these factors are related to each other. Same way, tall stature. If your female is having high tall stature, like 5 feet 9 inch, they're 20 times more at risk to develop breast cancer as compared to the female having height of 5 feet 4 inch. Obesity is a big risk factor, and quite high obesity have been seen in the China, India as less as compared to the rest of the countries. So obesity is a big risk factor for the breast cancer. Dense breast, OCP use, all these are the multiple risk factors which can contribute with the development of breast cancer. Family history is a risk factor for the breast cancer, and smoking, alcohol is itself a risk factor for the breast cancer. Radiation exposure due to some chest at the teenage can be a risk factor for the breast cancer. There are certain factors which decreases the breast cancer that, like if you can go for, if I have some genetic mutation, we can go for the upfront surgery, like in the case of Angelina Jolie, who underwent the breast cancer surgery due to BRCA positivity. So you can prevent breast cancer with early mastectomies at the very early age if they have some genetic familial disorder. Bilateral ovarian cervical oophorectomy, some drug use you can prevent in this way. Breastfeeding for 12 months prevent the breast cancer risk. Physical activities and same way, low fat intake is the risk factor which can have more fruit intake, less fat intake, more vegetable, definitely going to play the role in the prevention of the breast cancer. There are certain factors about it you don't know, but there are certain myths about it also in the cancer, like processed meat. Processed meat definitely have a big risk factor for the colorectal cancer and the gastric cancer. Fiber intake and is a risk can prevent this risk of can prevent certain colorectal cancer and gastric cancer because in this way you can have the better gut motility. Use of calcium, vitamin D, some SAID, some BISFORM. We don't have good data on all these things, but these are the factors which can play some role in developing the cancer. Certain factors which don't have any role, and usually patient ask that the caffeine intake can have some issue with the cancer. No, we can say that we don't have good data. Putting them using the hair dye, we don't have a good data. Some surgeries like abortion, all this thing, we don't have any good data for the development of such type with the cancer. There are certain myths. I'll just skip. Try to do it early because breast cancer is affect only the woman. No, it can affect any age woman, not only specifically the old age female. It can affect any woman. Talking with the breast cancer about the breast cancer causes breast cancer, it's a myth. There is no fact about that. Using drug like some local therapies like herbal treatment, all these things, we don't have any. There is no cure in such type of the treatment. Same way, touching with some heavy material like metal and all these things, there is we don't have any data. Same way, mammogram doesn't have some high radiation risk. It's quite safe. Okay. If risk is there, you are likely to get me. If there is families having the breast cancer, then the kids will be having the breast cancer. It's not like that. The risk is high, but no, it's not the cause. Same way, breast cancer is a death sentence. It's not a such factor. No, it's a treatable disease. Breast cancer is preventable. It's not preventable. You can give some treatment to. You can do some good screening to pick it early, so then it can be have a very well managed. Same way, if you are having no risk factor, then you are spared. No, there are many other risk factors which you even yet don't know they can cause cancer. Putting cell phone, no, like early breast cancer don't have the recurrence. They can recur also. All breast cancer are treated in the same way. No, it's a treatment. All breast cancer treatment is different. Coming too much with the consuming too much sugar. It can be the risk factor, but no significant data on that. Sugar can be used, is a lethal factor for many other diseases also, but it doesn't mean that sugar is the only cause of cancer. Okay, if there is lump, there is no cancer. So I just summarize all these things that we looks to be quite safe in the international community. Pakistani population looks to be quite safe in the international community because we have less incidence of the breast all types of cancer, specifically the breast cancer, as compared to the international community. But this ratio is quite high in our region, in our regional country. So we have to work for this all these things. Factor that may be creating this difference looks to be that we take people in this region take more fat intake, our body weight is quite high, age at early menarche and the less lactation, fear pregnancy, and later age of the first birth. These look to be some factor which can contribute high incidence of breast cancer in this region, but may not be the true fact. There may be many other factors which you have to work for all these things. Then this is my cancer center which I've just shown in the initial. So, sir, if you have time, I can tell you something more about this advanced technology, or if you just want to take some question answer from the audience, I'll be happy to answer all this. Thank you very much, sir.
You have 5 minutes if you like to say something in 5 minutes. You are most welcome.
Okay, I'll try to answer. There are a few questions on this chat box. I will discuss with Dr. Javed Khurshid. Thank you, Doctor, for inviting me. And 30% increase in the last year, or else. Any specific reason? Sir, my question, try to answer this question, then I can add them.
Okay, fine.
There is a one question by Muhammad Wasik Shahid. Any specific reason why you suggest which you suggest may be involved in causing the high number of the breast cancer patient as compared to the first world country? So I have answered. There are many reasons which you are thinking are in this our region. There looks to be the people are taking more fatty food, less vegetarian, less physical exercise, less lactation. Same way, we people are not well aware of this something like in the form of breast cancer screening. So this could be the one of the reason that we people are getting cancer, but as compared to the rest of they are more tall people. They have more family histories also quite high. So this could be the one of the they're getting more cancer over there. But truly speaking, we don't have any single word to say like this that why you are having less and why the Western countries are getting more cancer. This one of the reason which I think they are screening their people quite regularly. We people have the poor screening tool. They are calling their public regularly to come for the medical tests. We don't have any medical facilities available at our regional level by which you can pick the cancer earlier. If we can have this much of the facilities in this region, we may be having the high number of the cancer patients. Dr. Rafia is asking poor registry issue in the Bangladesh, India, and Pakistan. Definitely, Madam Dr. Rafia, she is our colleague from the Noori Hospital, and our cancer registry and in this region definitely this issue. But all this data which I have collected from the IERC, they have collected the data from the Punjab Cancer Registry. Now, sorry, now Pakistan Atomic Energy Commission is collecting our own data, and we have the published this data also. This available on the websites also. So you can say when you have the more data, we can better comment on all these things. Any other question, or would like to start something, sir?
Can I ask one question from my side?
Yes, sir, please.
Dr. Askar, you have shown a slide in which I see very interesting data, and this is, I think, the first time for me to correlate the cancer, breast cancer especially, with the height of the people. How much data do you have about that?
Sir, this is the international data. It's the published data. If they are saying, like if you just see why the female are having in the Belgium and Australia having more cancer, their female are quite tall. If the height of the female is 5 feet 9 inch, they are 20 times more at risk to develop breast cancer as compared to the female who are having the height of 5 feet 4 inch. So if you can say you have also gone abroad so many times, you must have seen that their female in that region, they're having quite tall height. So this is an observation which has been reported in the literature that this could be the one of the risk factors.
Maybe something related to genetically in that sense.
Yes, sir. Genetic factor definitely have the many other mean if the genetic testing in the family patients have family history.
अब तस्वीर खींचो इसमें.
Specifically, the two genetic mutation like BRCA1 and BRCA2 are there. Their female are 80 to 90% chance to develop the breast cancer in their lifetime. This is the reason the famous actress Angelina Jolie underwent the bilateral mastectomies because she was BRCA positive. So if the BRCA positivity is there, then definitely we recommend that all those female can undergo prophylactic surgery to prevent the future breast cancer.
Okay, Dr. Nadeem, do you like to comment a little on that? I like to hear your comments too. What your research and expertise says about it.
Sir, according to our expertise, and whatever our team has done up till now, we are very much worried about the lack of registry issue. And Dr. Asghar Hussain Asghar will agree with me that unless we have 100% penetration of the registry, saying any cancer's name, whenever say any cancer name from my mouth, I have to be very, very careful. Now, Atomic Energy Commission took this step, but that was only recently. So that will cover 85% of our Pakistani patients. So now whatever I will say will not be 100% accurate because it is only covering the Pakistan Atomic Energy Commission registry data. So my observation is that we cannot make any comment as a clinician about genetics because see, we don't have that data, we don't have that backup to just by hearsay remarks or by something which is very lousy, because it will be crude data, So better we admit that we have to wait for a few more years. Now you will ask Dr. Azhar Hussain Asghar, they are doing a lot of genetic modeling and things now in their patients now. But to be honest with you, the other countries who are quoting their data and making correlations with two, causation, cause and effect, are doing this since the last 40 years now. Some of them 50 years. So that is why I have my own reservations, because my own, practice will only be covering 2.6, maybe 3% patients. Pakistan Atomic Energy Commission is providing services to 85% of our country's cancer patients. So I think that is why important thing is not to make anything about the correlation so accurately unless we have the gene data with us, etiological data. And when I say etiological data, that means all risk factors, not few. So at this moment in time, I can confidently say about tobacco. Now,
Dr.
chewable
Nadeem,
tobacco has shown
Dr. Nadeem,
nothing
I
can be
will
caused.
have, okay, thank you. Dr. Nadeem, I will have the comments of Dr. Asghar afterwards. But here I like to point two problems which we had
Sure.
initially. First is the registration of the patient, and second, back reporting of the patient after treatment that they sometimes don't report in the developing countries like ours. They are the two big problems, and Dr. Asghar is the best person to educate us on this, because I know he gets a lot of patients there. Uh,
Hmm.
I like to have his comments too. Thank you.
Please, yeah, because he
Yes,
is the right person, because see, they have an open door policy. They are in the public sector. I am, sir, working in a private sector. So I know that the patients have financial constraints, but he is the person who can give us the best guidance, inshallah. So I'll stop here. I will let Dr. Asghar to speak.
yes,
Please,
sir, I agree with
Dr.
this.
Asghar.
I agree this your point that the cancer patients are coming to us quite a big number of patients. And we have a poor cancer registry. Pakistan Atomic Energy Commission is now specifically working on that, and we're trying to register all these cancer patients from all these
Asghar,
states.
Dr. Asghar, we are trying for it for last 20 years. You know that.
No,
You
sir,
know,
no, sir. We have the two version published. One version is available, and second one of 22, 24 has been published book in the booklet form, and it's being published in the international forum also. And we have now well developed cancer registry now, sir. I'll show you all this thing. There is one question which has been put by Hafiza Mariam Ghani. If you sir allow me, I can read this question and then try to answer. She has written, I have one question to Dr. Aswad. Why we doctor have more insist on the disease treatment? Why don't we insist on the prevention or even work on the post-complication prevention to promote healthy lifestyle? I am the cardiopulmonary rehabilitation physical therapist. We should include all other specialties as well to fully recover the patient. What do you say? Sir, Naeem Bhai would like to answer this question.
I think it is very, very obvious. Very obvious. You have to set up priorities. I showed you clearly with international data, full backup. We don't have 200 linear accelerators, which we need today. This is for those patients who are diagnosed as cancer. They are diagnosed, they have cancer, they want treatment, and we have no machine. So just imagine what else I can put my energy on. So this is very important to understand that there are many things which are related with literacy and resource availability. Clinician doctor is there to treat cancer patients, and we are short of doctors, specialists. We have attrition about 80%. People who get training leave the country. Doctors, engineers, and these technologists and physicists. So that is why where we should be making our priority. Priority is for cancer patient who has a diagnosis. Now he want treatment. Who is going to treat him then? If I'll go and lecturing people about anti-smoking, who's going to treat the patient? So this is why it is very good to say. It looks very fashionable that prevention is better than cure, and do something to prevent cancer. I know it is important. It has to be said, but we don't have people. So for that, Ministry of Health has to designate what is happening in other countries. There are ministries who are looking after this. So I am myself and Professor Dr. Asghar Hussain, Asghar are clinicians. We are doctors. We are MBBS, and we are qualified specialists. We have to treat our patients. We cannot leave our patient and go somewhere else. So this will be something to do with the policy makers who are making this, administrative people. Pakistan Atomic Energy Commission has 21 hospitals, but that is for treating cancer patients. Still, they are doing a lot of prevention work. I must acknowledge them, but I don't think we can do too
Second,
many
I would like to
things
add,
in
sir.
one go.
Sir, I
Please,
would
yeah,
like to.
you have to add because you have more experience than me in terms of seeing patients. You see more patients than me. So please add.
जी मैडम Hafsa, the answer to this your question is given by Sir Abbasi. Second more important thing that the cancer is usually not so preventable disease. As you can see, the TB is a preventable disease. You can have very good treatment prevention campaign. You can prevent the disease. But cancer, breast cancer, and most of the cancer not the preventable. We don't have any good data to say that this is one of the cause. So the major cause of most of the cancer is the growing age. So as the patients having the growing age, they're high likely to develop multiple type of the problem, including the breast and including the cancer also. So only thing which you can do for the cancer is to detect early. Breast cancer, if you can detect early, definitely you can cure the patient early. If your detection rate is quite high, poor, definitely you're going to see the patient, you're going to see the patient at quite later stage, then definitely mortality will be high. So prevention is not so good term to use for the cancer, but early detection is a good term to be used for the cancer. Sir, over to Khurshid sir, please.
This is well, this is a debate which we always have, that how we can handle those things and how the patient should come on time and the treatments and whether the awareness is done before, we should spend more money on the awareness, or we should spend more money on the prevention, or we should spend more money on the treatment. So these are the few things. In some countries like to have spend more money on the awareness, and some like to have more money on prevention, and ultimately they have to do it. But see, Dr. Abbasi talked 2-3 times about the Atomic Energy Commission. Atomic Energy Commission, they have the policy that we should treat everybody who reports and whatever we can do. And the treatment is 90% free in our hospitals, and they are the basic cancer treatment facilities. And I'm glad to have Dr. Asghar here for the comments, because he is one of the largest. He's dealing with one of the largest hospital which have a lot of facilities, and I have seen it developing and growing and helping it to grow. Here I like to क्या नजर आ रही है? Here I like to have the final comment or the closing comments. With this, I finished the two lectures, and I like to have the comments from the advisor OIC Comstech to get the final closing remarks. So we after that we can finish. Here, I like to mention that in the last, I will take 1-2 minutes to give the guidance what we are thinking of the future in OIC countries. Can I ask Dr. Muzassir to give her comments? Thank you, Dr. Muzassir. Poker.
Right. Assalamu alaikum. Professor Dr. Honorable Professor Dr. Mohammed Mahisa, Professor Dr. Javed, and respected speakers and dear participants. As we come to close of today's important seminar, I would like to express my sincere appreciation to all distinguished speakers for their insightful and highly relevant presentations. Their expertise and practical experience within OIC countries have enriched our understanding of how to strengthen cancer awareness, advance radiation therapy technologies, and build sustainable medical physics capacity across our regions. I also extend my heartfelt thanks to the organizer, Professor Dr. Javed Khurshid, for arranging this webinar. And I'm really thankful to all of you for your participation and attending it. Thank you very much.
Thank you, Dr. Israr, for your comments, closing comments. And after the closing comments, I like to make an announcement here. In the last, I like to make an announcement on behalf of Dr. Iqbal Chaudhry, with whom I have discussed, and he like to establish a collaborating forum, and that collaborative forum has already been discussed with Dr. Asghar and Dr. Nadeem, and that will be OIC Cancer Advisory Forum. In this, we like to have some known, very well known cancer specialists to guide any questions, any thinking, or any suggestions, or any direction to the cancer doctors from OIC countries, so they can put their cases on there, as we are already doing. I am also a member. Asghar is also, Dr. Asghar is also a member. Dr. Nadeem is also a member of Cancer Advisory Board, and then we can put those cases on the Cancer Advisory Board if required. So I am suggesting to have OIC Cancer, especially OIC Comstech Cancer Advisory Forum, which will be published on the website, and we like to have the members, and we like to have questions or cases from OIC countries on that board, and so we can direct them to the network. From the network. So here I like to have one more comment from Dr. Asghar and Dr. Nadeem on that. Dr. Asghar.
Sir, I have no issue, and I would like to the part of this your advisory forum. Whatsoever the case they will put on the WhatsApp, will try to answer immediately, because this will be, I think, a good collaboration with the OAC countries. Definitely, we're going to learn from them, and we're trying to get their experience also. If the countries like South Africa and all this, where the cancer facilities are not so well established, our services will be always available. There are Muslim countries, and we like to help them as our Muslim brother. Whatever the financial, this your advisory support will be there. We'll try to manage from our forum, inshallah. We'll do that.
Thank you so much. Thank you so much. I like to have a comments from Dr. Nadeem too, because
I think I will second it, but the only thing, because we are in many international forums, as you know myself, that I'm a very frequent traveler outside for taking exams postgraduate. So my request only to will be the central office of OIC, which is headed by Professor Saab, Javed Khurshid Saab and Iqbal Chaudhry Saab, that please make a registration system, so that at least myself and Dr. Being clinician, you know that who is actually registered in that particular group.
okay.
This is very important, so that we will know their expertise. We can do mutual subgroups. Sometimes we have to talk with 2 or 3 people only. So it will be a gatekeeper system, in which we welcome everybody for an OIC, but then they have to be in one of the clinical services setting. Not only doctors, no, not only doctors, but technologists and everyone. But at least we'll know their introduction. It's very important for any forum to
Okay.
be successful, that we should know each other. But
Dr.
everybody is welcome.
Abbasi, Dr.
Most welcome.
Abbasi, thank
Yeah.
you so much for the comments and for the direction. And we will sit together and work on this, and that will be according to your and Dr. Asghar's advice. And we will like to have it successful. Thank you so much.
Thank you, sir.
Thank you.
Welcome.
Thank you, everybody.